begin assessing the amount of
What about yourself?
version that a patient may have.
I'm gonna be asking.
So you're sharing them, right? So you're sharing them, right?
English?
No hablo inglés.
English? I'm kidding.
So again, this is my patient. I'm
Of course.
suspecting may have
It's
some
gotta-
excessive anaversion or excessive retroversion based off of what I see in my objective exam or some complaints that they may have. So what I'm gonna do, I'm gonna palpate the greater trochanter, okay? And then I'm gonna go into internal and external rotation, looking for the greater trochanter to be parallel with the table or most prominent, okay? So what I would do, find the greater trochanter, okay? And I'm gonna bring them into internal and external rotation, looking for where the greater trochanter is most prominent, and I feel it parallel to the table. And then what I would do is measure that angle, okay? So I'm actually gonna bring him in a little bit of adduction here. Relax. And so right there, I feel it parallel, and I would measure that degree of internal rotation, okay? If he's in a more neutral position, I'm thinking he's more retroverted. And then if he's in more external rotation, he's excessively retroverted. So normal is anywhere from 8 to 20. I'm looking for excessive anaversion or anything that is in neutral or retroversion, okay?
So
And
then, do you want us to know 8 to 20 or 8 to 15?
So 8 to 15 is normal. Anything above that, I'm thinking excessive anaversion. Anything below 8, I'm thinking retroversion, okay? Have you go supine.
Is it more than 8 anti-version?
Above 20, excessive antiversion.
Below 8, retroversion.
Beautiful.
I was gonna ask about that. The below 8 is retroversion?
Yes. With that
But that's if he's internal rotation?
Yes. Excessive
We only have
interrotation.
one set of, one stethoscope that I could find. So
Yeah, 'cause
next lab, bring your
if it's
stethoscope and we
neutral,
can
it's
actually
just
practice this
retroversion.
test.
If it's
Okay,
internal rotation,
so
it's excessive.
what you're gonna do,
Makes sense.
you're gonna have the stethoscope. What I like to do, I have my patient find their pubic symphysis. So I have them bring your heel, the heel of your hand, and then come right down on your pubic bone. Okay. And then what I'll do is I'm gonna bring my hand right there. Good. All right. And so what I'm gonna do, I'm gonna go immediately left of that, okay? I'm just gonna bring up your shirt, okay? Yeah. So I'm gonna go immediate left of that, okay? On his pubic bone, and what I'm gonna do, I'm just gonna tap his patella and listen for the sound. I should hear a sharp sound coming through the stethoscope, okay? If I hear something dull, then I might try it with a tuning fork, okay? So I can take a tuning fork, all right, and put that on his knee and listen for the sound to see if I have a continuous sound coming up through the stethoscope. If it is dull or you're looking for a dull sound, okay? If you have a dull sound, then you would move on to some other tests to confirm any kind of osseous pathology that you have been thinking.
So you said we're looking for a dulled sound,
A dull sound.
but abnormal says dulled side considered abnormal. So it's just
So you're so you're going to compare side to side. So you would look at his left side, and then you can compare that side to his right side. Okay, good question. All right. So if that is positive, I can continue with my assessment. I can perform the fulcrum test or the heel tap test. Okay. So I'm going to do the heel tap since you're already supine. So heel tap, you're just going to bring them up into flexion. Okay. And then all you're gonna do, make a fist, and you're gonna strike the heel, okay? Okay? And then you can increase your degree of force that you're putting through the heel, okay? All right? So you want to strike it, you want to start gentle, but then you want to strike it because you're almost simulating what heel strike is going to be like while they're ambulating. So they're going to have a lot of pressure and force on their heel while they're ambulating. So again, you're thinking start light and then increase the amount of force that you're putting through there. And they would report pain with that test. Right? I'll have you go supine or seated. So for the fulcrum test, this is another test that we can use to see if we can create basically a fulcrum over the site of fracture that we're thinking, okay? So you're gonna take one arm, you're gonna start distally, okay? And then all I'm gonna do is put force down through the distal femur, seeing if I can reproduce his pain symptoms. I can work myself more proximal, okay? Doing the same thing, trying to create a fulcrum to see if I can reproduce any pain. I can work my way up. On the fulcrum. And if he reports pain at the site where my forearm is, that would be a positive test.
You would always recommend us to do distal or proximal, or okay,
Yeah.
so not
So,
proximal.
yeah. So you're going to start distal, and then you'll work your way up proximal. And then, so these tests are positive. You've done the pubic percussion test. You've tried the fulcrum test, the heel strike test. You can also progressively increase the load that they're doing. So you can have them do a double leg drop test, okay? So you can have them on a step, stand there, and then you're just gonna drop down off that step, looking for reproduction of any pain. So you're gonna have them step up again, jump down, boom, and they should report, if they're having any kind of stress fracture, osseous pathology, they would report pain with that test. You can increase the load by doing a single leg drop down test, or I just like to have my patient hop in place, hop a couple times in place.
Could you also see them trying to avoid touching the heel?
Correct. Correct. So that's one of the things that you would look for. You would cue them. I want you to jump down and land on your heels when you're coming down.
So you do land on it?
Correct.
And then, like, on the second one,
He landed on his toes. He landed on his toes.
He also landed like, right.
A little bit. A little bit.
Yeah. So you would cue him. Yeah. So again, the cue is going to be, I'm going to have you jump down, and I want you to land on your heels. Okay? And you can have them do that a couple times to see if that reproduces any pain. Okay?
And the pain would be where at the hip?
It would be
Oh, the whole thing?
in the bone. It would be either at the femoral neck, the shaft of the femur, like wherever you're suspecting the pathology.
Because like if they land like heavy like that and like it's gonna be painful.
Yeah.
So like how would you distinguish the type of pain?
It would
that
be
they're
a
supposed to
part of your entire objective exam. So you're suspecting fracture or you're suspecting some kind of bone-related issue that's contributing to their hip pain. And so this would be the test that you to rule in or rule out.
So the first bullet point, only perform if your other tests are negative. So if that's like you get the rest of these negative, but you're like, I still think you got a fracture, or I still think something's going on, then you would progressively load the amount of intensity. Okay? Because you think about the heel strike test, like how much force can you actually put in while you're striking with your heel? If they have a significant fracture, yes, that would be positive. But if you want to increase the load, you can start increasing their body weight while they're performing these tests. No, because if you have a gait belt, you're taking the weight, like you're essentially taking some of the weight off from the test. So this would be like a patient I'm suspecting some type of stress fracture or something. So I wouldn't do this in my,
elderly patient that might have osteoporosis or something like
Yeah.
that. I'm not gonna do it. I would do it in my younger
There are-
patient.
Yeah, people who are functional but still have pain.
Correct. Correct. And again, with all these tests, you still have to confirm it. So this would be, you know, something that you would take to your doctor and say, you know, I got this test, the fulcrum test was positive, the heel tap was positive. They also had pain with a single leg hop. I'm thinking they might need some advanced imaging to rule in or rule out a fracture or rule out some kind of bony pathology. So this is all a part of your objective exam that you would use when you're conveying that to a doctor or physician about what you're suspecting is going on. Okay. All right. Let's try those. Let's try your Craig's test, then your fulcrum test, your heel tap test, and your drop